All right, sounds great. Thank you. Excited to share my talk on alcohol withdrawal. This was really inspired by kind of my own confusion as an intern about all the different treatment options, and and also kind of the temptation to just like click the protocol and let it play out. And then as a second year, wondering like maybe I should understand this a little bit more. And so here we are. I have no disclosures to share with you. My objectives for today are to try to understand the pathophys of alcohol withdrawal a little bit better, spend a fair amount of time covering the principles of triaging patients between outpatient, inpatient, and the ICU, and then getting into the evidence behind different pharmacologic treatment strategies, kind of focusing on what the latest is on benzos versus phenobarbital versus also adjunctive treatments. Some important things that I'm not going to talk about, but that are really important overall, are screening patients for alcohol use disorder and treating alcohol use disorder. Okay, let's start with a case. Mr. Oz is a 44-year-old man who presents to the ED after a ground level fall in the setting of acute alcohol intoxication. The ED has completed its trauma workup, splinted his wrist, he's feeling a lot better, and has been resting comfortably for a few hours in the ED before he begins to have tremors and increased irritability. His vital signs are showed below and notable for hypertension and some tachycardia. So I want you to mull over a few questions regarding this case off the bat as we get into the rest of the talk, including what other history and workup should be obtained in somebody who you suspect alcohol withdrawal? What are the risk factors this patient has for going into severe withdrawal? Where is the appropriate treatment location for this patient, whether it's sending him home, bringing him into the acute care setting, or talking to the ICU? And lastly, how will you choose the best treatment strategy for this patient? First, I'll cover clinical presentation, which is something I think a lot of us are already familiar with, but I just want to refresh your memory and acknowledge that, and we've all seen these tables in whatever resource you use about like the timing of each symptom coming on. And I personally find it pretty impossible to remember. So to refresh your memory, alcohol withdrawal state is really an overabundance of neuroexcitatory signaling, which leads to symptoms of, in the mild case, anxiety, tremors, agitation, headache, and can progress to some pretty severe symptoms. As we get to the moderate severe category, we're talking about vital sign changes, hallucinations, seizures, and then of course, delirium tremens, which is defined as delirium plus cardiovascular collapse. I'll turn your attention to the graphic on the right side of the screen. This is just a visual representation of those very difficult to remember tables on the timing of each symptoms. I think the two most important things to acknowledge are that seizures can come on quite early in the withdrawal course, as early as 6 hours after cessation of alcohol. And delirium tremens is pretty exclusively something that happens later in the course, between 48 and 96 hours. All right, so let's talk a little bit about pathophysiology. I show this very complex flowchart to just explain that there's actually a lot of nuance to it. I think we probably are all familiar with the GABA receptor and how alcohol acts on the GABA receptor, but there's pretty good evidence stating that the withdrawal state affects a lot of other neuro pathways as well, including dopamine and NMDA. And this might be why you see symptoms in alcohol withdrawal like hallucinations connected with the dopamine receptor, like seizures. But for the purpose of this talk, I just want to focus on the simple balance between the main neuroinhibitory transmitter GABA and glutamate, which is the main excitatory neurotransmitter in the brain. So this graphic is supposed to be a scale with GABA on one side and glutamate on the other. And the balance of these two pathways is what keeps you at your normal baseline consciousness. When someone's acutely exposed to alcohol, it stimulates the GABA receptor, putting more weight on this side of the scale and leading to sedation. And then as the body is more chronically exposed to alcohol, the brain starts to adapt. It actually downregulates GABA receptors, so it's less responsive to that alcohol depressant stimulus. And it also upregulates the glutamate pathways to reach a new homeostasis of consciousness. And this is why someone who's been chronically exposed to alcohol can have a pretty impressively high blood alcohol level and maintain normal consciousness, whereas that same level in somebody without that exposure chronically would maybe lead them to be extremely sedated or comatose. So this is the new homeostasis for chronic alcohol exposure. And then withdrawal is when you take away that constant gas pedal on GABA, which is alcohol use or exposure. And the body, because it has compensated so much to adapt to that constant alcohol stimulus, there is a major decrease in GABA stimulation and a major unopposed excitatory response with upregulation of glutamate. And that's what leads to your symptoms of withdrawal that I talked about earlier. To summarize pathophysiology, essentially alcohol binds the GABA receptor, and so acutely leads to depressant effects in the CNS. Chronic exposure downregulates GABA receptors over time, leading to this new kind of inhibitory excitatory homeostasis. And then abruptly stopping alcohol intake will lead to a huge shift toward more neuroexcitatory stimuli and alcohol withdrawal symptoms. And then lastly, as I showed on the first slide, there are actually a lot of other neurotransmitter pathways involved, which may explain the symptomatology of alcohol withdrawal, but are a little too complicated for your humble general practitioner to get into. All right, any questions about the pathophys before we talk about triaging patients? All right. Feel free to interrupt me at any time. So we'll talk about how to triage patients who present with alcohol withdrawal. And I want to start with just taking a step back and looking at epidemiology. The prevalence of alcohol use disorder in the US is about 14% of individuals, and about 50% of those with alcohol use disorder will experience withdrawal upon stopping alcohol consumption. Among those with AUD, the very, very large majority will experience mild withdrawal. So that 50% that has withdrawal, the large majority, like 80, 85%, will be a mild course of anxiety or tremors or tachycardia that self-resolves in about 48 hours. About 10% will go on to experience withdrawal-related seizures. 3 to 5% only will progress to delirium tremens, with the lifetime risk of DT about 5 to 10%. So with the very small amount going into severe withdrawal, why does it matter to bring people into the hospital to treat them? And it's because the mortality of delirium tremens is quite high, 15 to 40%. So people can die if they progress to severe withdrawal. And so this epidemiology to me is why triage is what makes triaging so important. Is we need to figure out who's at risk of severe withdrawal in DT because they could die. And so trying to predict who will go on to that severe withdrawal is the key part of triage. So I'll spend a few minutes just on evaluation because this kind of frames how we identify who's high risk of severe withdrawal. Pertinent history is all stuff I think everybody is familiar with and has practiced. You have to get a thorough alcohol use history to assess their kind of risk factor for chronic exposure to alcohol. Timing of last drink is extremely important, as I showed on the earlier slide about presenting symptoms. And then withdrawal history is also key. Have they been hospitalized before? Have they been admitted to ICU before? Have they had seizures? And have they experienced DT? We assess current symptoms mostly with the CWA test. And then on exam, it's, in addition to a general exam, key things to look out for are, is this someone in such a severe withdrawal state that they're not protecting their airway? And then making sure to carefully examine their cranial nerves and look for oculomotor dysfunction to identify Wernicke's encephalopathy. Interestingly, the oculomotor dysfunction in Wernicke's most commonly is horizontal nystagmus, but it's also very common to have multiple oculomotor issues at the same time. So they might have horizontal nystagmus plus a diplopia or another thing. And so just any kind of oculomotor abnormality is notable in these folks. And then testing their cerebellar signs with finger, nose, and gait is also key. And then proper workup for anyone you suspect has withdrawal would include a blood alcohol level, because that helps determine their risk of severe withdrawal. Considering Eutox in the right clinical context if you think other substances might be contributing to the picture. And then a basic laboratory workup, including a hepatic function, is important. And then keeping an eye out for concurrent illnesses like pancreatitis, because folks with alcohol withdrawal might be at risk for those things, but also conditions that might confound their presentation. For example, someone who's septic and tachycardic might confound your evaluation of them in the withdrawal context. Okay, I've got a poll question without actually launching a poll. This will be just kind of thinking on your own, and I'll cover an answer here in a few slides. So which patient do you think is at the highest risk of experiencing severe withdrawal? A is a 71-year-old man with AUD, hypertension, hyperlipidemia, who has a CWA of 15, heart rate of 95, blood pressure 165/90, a BAL of 0, and no history of complicated withdrawal. A 45-year-old with AUD, recurrent pancreatitis, CWA of 18, and no history of complicated withdrawal with tachycardia and hypertension, BAL of 50. A 60-year-old man with AUD, multiple hospitalizations for alcohol withdrawal, but no seizures, who has a CWA of 12, slightly tachycardic, slightly hypertensive, and a BAL of 210. Do you think all three of those patients are high risk for different reasons, or not sure? So we'll cover some of the data on predicting severe withdrawal, and then we'll get to an answer. What I think is the answer to that question. So a lot of studies have actually tried to look into this, like what factors will predispose somebody to progressing to DT or seizures. And the kind of TLDR is it's pretty hard to predict. This big meta-analysis in 2019 by Wood et al. Looked at 14 high-quality studies evaluating different risk factors. They looked at 71,000 patients, 1,000 cases of severe withdrawal with only 53 seizures and 250 cases of DT. And they found that the only two individual predictors were correlated with severe withdrawal, and that was a history of prior DT or an admitting blood pressure over 140. Now, they've also looked into combination risk scores, specifically one called the PAUSE, or the Prediction of Alcohol Withdrawal Severity Scale, with good correlation. So that's something that's emerging. It doesn't seem like it's in clinical practice frequently, but it does have pretty good predictive value. If you can see down here where my mouse is, a PAUSE of 4 or greater has a likelihood ratio of 174 for severe withdrawal. So you could consider using that. And then other studies have suggested a few other possible risk factors like comorbid acute illness or having symptoms when the BAL is greater than 200. So back to the poll question. I think we can justify, based on the literature that we know, without 100% certainty, that patient C is at highest risk of severe withdrawal, and that's because they're experiencing withdrawal symptoms with a BAL greater than 200. It means that they still have alcohol on board and are already experiencing withdrawal symptoms. Other risk factors for all of these patients seem to be an admitting blood pressure that's hypertensive or greater than 140. But I do think it's reasonable to say I'm not sure, because there's a lot of clinical judgment that has to go into this, and there's no clearly correlated risk factors. Okay, I just saw the questions in the chat. Age. I don't think age has a really strong predictive value. They did look at it in this meta-analysis. I think younger patients are more likely to experience withdrawal, and older folks may have a slightly higher chance of developing severe withdrawal, but I'd have to double check that. And I think that the likelihood ratio is not that great for age, so it wasn't considered a very good predictive value or a good risk factor. Okay, let's keep moving on. So I want to just focus in on what we do at UW. So in the protocols in the UW system, we consider the following features predictive of severe alcohol withdrawal: prior history of DT or seizure, presenting a CWA greater than 20 despite receiving treatment with benzodiazepines or other GABA medications, experiencing symptoms with a BAL over 200, and a patient presenting with a co-occurring illness. And as I said, clinical judgment is still very important to this decision. And though not commonly used, you can consider using the pause, which is available on MDCalc. So since it's hard to predict, you might say, like, can you ever feel comfortable sending someone home from the ED if you think they're having alcohol withdrawal? And I think the answer is actually yes. Somebody who is having mild to moderate withdrawal and doesn't have clear risk factors mentioned on the previous slide can be sent home with return precautions or close follow-up. So these are the requirements of sending before you send someone home. They should not have a history of severe withdrawal, meaning no prior seizure, DT, or ICU stay. Their CWA should be under 10 to 15 prior to getting any treatment in the ED or in your clinic. No concurrent sedative use disorder, like they also use benzodiazepines, which can make the picture more complicated. They should have a low BAL, meaning under 200. They should have ideally a stable home environment with the ability to call to clinic if things get worse, or answer the phone or respond on my chart to be checked up upon. All right, back to our case, just to fill in a little bit of details about our patient, Mr. Oz. He has known AUD. He's been admitted to the hospital for alcohol withdrawal before, but has never had withdrawal seizures or an ICU admission. He lives in an apartment by himself. He works in construction. He drinks 6 to 12 beers a day and has done so for the last 10 years. And then his initial labs are pretty unremarkable, apart from mildly elevated transaminases and a BAL of 180. So Mr. Oz was found to subsequently, after his kind of calming down in the ED after his trauma workup, a CWA of 15. He was given 10 milligrams of diazepam and then remained uncomfortable with CWA still at 13. So got an additional dose of diazepam, 10 milligrams. And 1 hour later, his symptoms are largely unchanged. It was a CWA of 13. I'm looking at the chat here. Oh yeah, so Ananya's bringing up an interesting point. Oh, okay, I'm not sure. All right, we'll break in a minute for questions. So with this in mind, this patient has had a couple of doses of diazepam, still is having symptoms. Where would you triage Mr. Oz? Would you discharge him home with plans for close follow-up? Would you admit him to the medicine acute care service for inpatient treatment? Is he headed to the MICU, or still not sure? It depends. And as you're thinking that over, I will tell you a little bit about my recommendations for triaging the patient based on some literature review and some kind of best practice guidelines and our protocols at UW. I think, first of all, there's no obvious correct choice. Clinical context matters a lot. Expert judgment and patient trajectory after getting treatment is really important. But I'll say that most cases of moderate alcohol withdrawal, CWAs between 10 and 20, even a remote history of withdrawal seizure, can be handled on the acute care service. Clear ICU indications are a patient who's actively in DT, they have hemodynamic instability, or they are not able to protect their airway. They are for certain heading to the ICU. You should consider the ICU in the patients who are requiring medications every 1 to 2 hours and still experiencing symptoms. This, I think, is a little bit of a gray area, but I think it's just showing that there may be refractory to initial treatments and might need higher doses or a different option. You should consider the ICU in CWA over 20 despite receiving medications. The initial CWA over 25 would be suggestive, possibly, if they are having pretty significant symptoms with a high BAL, history of DT, or history of multiple, especially recent withdrawal seizures are reasons to consider the ICU. So I think we can justify admitting Mr. Oz to the acute care medicine service. He's still symptomatic despite getting a few doses of diazepam, but his COA is not that high. He does not have a recent or remote history of DT or seizures. And I don't think we can send him home because he's been treated with IV medications and is still having symptoms. So it would be a little risky to me unless he had a very clear follow-up plan to send him home. And like I said, clinical judgment at the bedside might suggest otherwise. Always take that into account. All right, Lauren's asking, does phenobarbital loading require ICU admission? I'll definitely get to that later. Short answer is no. You can load on the floor. You can even load in the ED. All right, so summarizing triage, determining the risk factors for severe withdrawal is the most important part of triage. It'll determine if you think they need to be in the ICU or not, and definitely will determine if you can send them home or not. Prior history of severe withdrawal, DT seizures are the strongest risk factors for severe AWS. Clinical judgment, integrating risk factors, the current severity of their presentation are important, and a patient's social situation must be considered, especially if you're going to discharge them home. Okay, so let's get into outpatient treatment. So like I've been harping on many times, clinical judgment, getting a handle on the patient's risk factors for severe withdrawal are important here in determining who's safe for outpatient treatment. So the first step is determine, is this patient safe? Or, if they're coming to your clinic and they're experiencing symptoms of withdrawal, what is going to allow you to comfortably keep them home or out of the hospital? And so contraindications to outpatient treatment are any history of withdrawal, delirium, or seizures. I think if they're presenting with a CUA over 15, really, it's not safe to send them home unless you've got a very, very clear plan. And then other relative contraindications would be a complex medical history or comorbidity like heart failure, decompensated cirrhosis, coexisting epilepsy, among others. And then complex psychosocial factors that limit follow-up would be a relative contraindication as well. I'll talk next about specific outpatient treatment regimens. Fixed dose regimens rather than like the PRN symptom trigger dosing is preferred for outpatient treatment in general. Everyone should get thiamine replacement as well. And this flow sheet here is from UpToDate. So there's a pretty good article on outpatient treatment for alcohol withdrawal on UpToDate if you're interested in learning more. But it divides it into a patient who is having very mild withdrawal versus those with moderate withdrawal. For CWA under 10, the suggested regimen is actually a gabapentin only regimen. So it's a taper of gabapentin starting with 300 every 6 hours, then every 8 hours through a 4-day regimen with a few extra doses PRN available. And this is pretty well studied in folks with CWAs under 10. It's just to help them get through those symptoms, which usually in these mild cases will resolve in about 48 hours. If their CWA is more moderate, between 10 and 15, then doing a fixed dose benzo taper is very reasonable. And you can choose between a diazepam taper or a chlordiazepoxide taper, doing about a 4-day regimen with a couple of 4 or 5 PRN doses if they're having more trouble is also pretty reasonable. And then, like I said in the prior slide, if they're having a CWA greater than 15, I would advise sending them to the ED for evaluation. And then an alternative regimen from our very own Jennifer Azen with the Addiction Medicine Group. She has a really wonderful dot phrase on an alternative lorazepam-based protocol. The dot phrase is .detox home, which you can feel free to steal from Jennifer Azen or myself. It's designed for a patient who wants to stop using alcohol, and you prescribe these things to help them prepare for any withdrawal symptoms. And it's also designed to be done with a trusted observer. So if they should have a friend or a loved one available to monitor them for the duration of their withdrawal. And just to highlight, this is the whole dot phrase. And I'll just highlight that it provides gabapentin as needed doses for the start of withdrawal. So they'll pick a time to stop drinking, and then they'll have gabapentin available for mild symptoms. If they have more moderate symptoms, then they'll have lorazepam 2 milligrams as needed available. And then it provides some return precautions or reasons for them to seek ED level care. If they're using lorazepam greater than 6 milligrams in 24 hours, that would be a reason, among a few others listed here. Okay, so to summarize outpatient treatment, treating in the outpatient setting is totally appropriate in the right clinical and social context. It's just about assessing risk factors and having a good follow-up plan. Gabapentin plus supportive care is an excellent option for mild withdrawal, and it does the job for most patients, including pretty good control of symptoms. Fixed dose benzo regimens are appropriate for moderate withdrawal as long as C was under 15. PRN lorazepam regimens are also possible, and check out the .phrase.t talks home. And if there's any risk factors of severe withdrawal or you personally feel uncomfortable as an outpatient provider, it is not wrong to send them to the ED for evaluation. All right, so any questions on outpatient treatment before I get into inpatient treatment, kind of the meat of the talk here? All right. Let me know. Okay, now I've got my eyes in the chat here. Okay, Zainab says, could you please talk a little bit about diazepam versus phenobarbital protocols for inpatient treatment? Okay, I'll get to that, Zainab, for sure.
Any thoughts on when to start naltrexone on the outpatient side? Like, could you do that a week later? Could you do it right away?
That's actually a really good question, and I'm not sure. You can definitely start it on the early side. I'm not sure if you should wait until they're kind of out of the most severe portion of their withdrawal symptoms. I would have to check into it, but that's a good question. All right, I'm going to move forward if that's okay. Hopefully we've got a little more time for questions at the end here. So this is intentionally supposed to be kind of a complicated, confusing slide to point out that there are lots of treatment decisions to make when you admit someone to the hospital for alcohol withdrawal, deciding to give them medications or not, to decide between a GABA-based protocol, benzos versus phenobarb. Do you add adjunctive medications? For benzo, should you do a symptom-driven protocol versus scheduled protocol? Which one do you choose? So a lot to kind of weigh, and so I'm hoping to clear that up in the next few slides. No matter what treatment regimen you choose or treatment approach you choose, there are a few key principles of effective inpatient management. Early, tight control of symptoms is best practice and will be helpful. There's pretty good data showing that if you control symptoms in the first 2 days with the withdrawal period, the risk that a patient is going to progress to DTs or another form of severe withdrawal is actually very low. Close monitoring with usually CWAS, sometimes with RAS, if you're in the ICU, is important to help determine if they need additional treatment. And then keeping in mind the purpose of treatment. Like I said at the beginning, it is preventing complications, so the risk of death or comorbidity from seizure or DT, and also to alleviate symptoms. And then you should always keep in mind that there's a lot of stigma out there for folks who are seeking treatment for alcohol use disorder. There can be a lot of shame among patients who are admitted for alcohol withdrawal, especially if it's been a cycle for them. So just be sensitive to that. And while they're inpatient, treating alcohol use disorder early is recommended. I would definitely recommend starting a medication like naltrexone prior to leaving the hospital. It just increases the chances that they're going to stay on it and not fall through the cracks. Alrighty, let's talk about benzodiazepine-based protocols. Zainab, I don't have a ton of information on fixed dose protocols with diazepam and stuff, but we can try to cover that a little bit too. I'll talk about mostly lorazepam-based protocols. This slide is to discuss that there's been head-to-head trials between symptom-triggered benzodiazepine protocols and fixed protocols like scheduled diazepam or chlordiazepoxide. And those studies found that there was reduced symptom severity, decreased length of stay, and a decreased total dose of medication needed in symptom-triggered protocols. So this, my mouse, here we go. This graph shows that in the fixed dose regimen, you can see that these patients are getting a lot of benzo doses for a little bit longer than the symptom triggered group, which is the dotted line. And they found there was no real difference in symptom severity. And so that's why symptom triggered protocols are favored. But there are reasons to consider fixed dose regimens. Sometimes if someone has more severe withdrawal and it's difficult to control with PRN medications, then it's fair to do a fixed dose regimen. And there is a fixed dose protocol in the UW and Harborview EPIC order sets. There's like I think it's called like so like the severe alcohol withdrawal pathway, and it's a fixed dose lorazepam regimen. All right, I'm gonna move on here. So this is what the typical benzo protocol looks like in our UW Harborview system. The order set is called alcohol withdrawal, standard for ICU and acute care. And there's a lot of information actually embedded within the protocol. There are links to studies that can drive the protocol, and you can see exactly what's in it. I'll just kind of briefly cover it. You can, if you want to come back to the slide later, you're welcome to it. It has a lot of the detail, but I'll just point out that everybody starts with step 1 of the order set, and CWAs are monitored at some interval based on how high the CWA level is. So a higher CWA, the nurses will be prompted to check more frequently. And then that corresponds to a given lorazepam dose. And then if a patient is having increasing CWAs after 2 doses of lorazepam, or their CWAs ever greater than 25, you'll be notified to progress to step 2, which is essentially CWA monitoring plus higher dose lorazepam. And then also built into the protocol is in the red box down here. So if the nurses see that their CWA persists above 25 for 3 hours at step 2, they'll call you to trigger a consideration of transferring to the ICU or some alternative treatment strategy. Okay, so I'm going to move on and cover what's the hype about phenobarbital, what's the deal, and hopefully it's an educational part of the talk here. So I will start with a hark back to our pathophysiology. So this is the pathophys of withdrawal, which I had showed you earlier. Benzodiazepines and phenobarbital both act at the GABA receptor. So they stimulate GABA, and they help control this mismatch between excess neuroexcitatory signaling and not enough GABA stimulation. Phenobarbital, unlike benzodiazepines, also will suppress glutamate activity, which is an argument for why there's a lot of interest in phenobarbital as being superior to benzodiazepines, that it might offer some kind of enhanced control of glutamate and reduce risk of seizures and other symptoms of withdrawal. And so the thought is you have better control, as I said, with kind of dual action of phenobarbital as opposed to benzodiazepines. So maybe there's a pharmacologic basis for phenobarbital being superior, but what is the actual evidence? A lot of the kind of first study showing that possibly there's a benefit to barbitals or barbiturates compared to benzodiazepines came with this 1978 Danish study. It was a randomized controlled trial of barbital versus diazepam, and showed that barbital was superior in treating delirium tremens, so better for severe withdrawal. There weren't a ton of studies between that one and some of the more studies in the early 2000s. So I have a little timeline here, probably something going on in Denmark. And then in 2013, there was a study in the EM literature that randomized patients in the ER to a standard lorazepam protocol versus that same standard lorazepam protocol and a single dose of IV phenobarbital. And they were able to show that the phenobarb group had reduced ICU admissions pretty substantially, 8% compared to 25%, without any difference in adverse effects. And so that kind of renewed interest in the research field about phenobarbital. And so there's been a number of retrospective studies comparing phenobarbital and benzos, and a couple of RCTs, though with pretty limited scope. And I don't have it kind of listed here, but these studies showed that phenobarbital was probably at least equal to benzodiazepines, possibly better in certain scenarios. And then I'll highlight a more recent study in 2021 that was a retrospective comparison of hospital power plans. So a hospital actually looked back at their patients who had been either receiving the phenobarb load protocol versus lorazepam, and they found similar efficacy with possibly a slight reduction in mechanical ventilation and length of stay for the phenobarb group. So I think in summary for the evidence, there's a lot of uncertainty still. There's possibly a pharmacologic basis for phenobarbital being superior. There's good evidence that it is safe and effective in treating alcohol withdrawal, and there's good evidence that it's non-inferior to benzos. That being said, the evidence that phenobarb is superior is limited by confounders. These studies were pretty small and narrow scope. For example, only in ED patients. Some of them only looked at ICU patients with severe withdrawal. And so the jury, I think, is still out on definitively what is better. And so the current state of practice is, according to the American Society of Addiction Medicine in their most recent guidelines, that it is reasonable to either choose a phenobarb or benzodiazepine protocol for first-line treatment of alcohol withdrawal, and that phenobarb is safe to give in any hospital setting, including acute care or ICU, and it is provider preference. The next two bullet points, I just want to kind of discuss, like, who might you choose phenobarbital for? Certainly in those with contraindications to benzos, there's a contraindication in patients with cirrhosis, specifically for diazepam and chlordiazepam epoxide. Lorazepam, I think, can be given in that scenario. Phenobarbital is also a good idea in benzodiazepine resistance. And what that really means is persistent alcohol withdrawal despite greater than 40 milligrams of diazepam or greater than 4 milligrams of lorazepam in 1 hour. So a patient who's getting a ton of benzodiazepine up front might be a good candidate for phenobarbital. I would add some cautions that phenobarbital has a lot more interactions. It's a strong P450 inducer, so we really want to think about interactions before selecting that in a patient. It cannot be given with most ART regimens. So patients with HIV who are on ART regimens, phenobarb is probably not going to work for them. It also interferes with pretty much every DOAC and warfarin. So it's not a complete contraindication, but you definitely want to talk to pharmacy in those folks. Okay, so this is our treatment protocol at the UW. The order set is phenobarbital protocol for alcohol withdrawal, very creative name. This slide lists in pretty good detail what the protocol contains, but I just want to highlight the general strategy, and then I'll go through an example case if we've got some time. So you start with a loading dose based on ideal body weight and risk for higher or whether you think they have higher risk or lower risk for severe withdrawal. So you can choose between a 10 mg per kg load and 15 mg per kg. Then they can get supplemental IV doses after the load. So patients who are still symptomatic can get multiple IV doses in addition up front to control symptoms up to a total loading dose of 30 mg per kg. I just want to point out that the protocol is built in with 3 supplemental IV doses, but this doesn't mean that you're limited at 3 doses. If a patient has a high enough ideal body weight, you can consider additional IV supplements up front if they're still having symptoms. It would just be outside of the nursing-driven protocol. And then on day 2, they start maintenance dosing, either higher dose or lower dose for 2 to 3 days versus 1 to 2 days. And then you're monitoring for toxicity along the way, checking phenobarbital level on days 2, 3, and 4. You should note that toxicity really doesn't begin until a serum level greater than 40. And toxicity manifests as a low respiratory rate. So using that as your marker for toxicity is the most important feature. Somnolence and them really sleeping a lot is okay, but watching their respiratory rate is important. All right. And then, like I said, you choose higher risk or lower risk. And what that means is the higher risk category is prior history of ICU admissions, seizures, or DTs, or they're having withdrawal with a BAL greater than 200. All right. I think for the sake of time, I'm actually going to skip the example. We can go through it if we have time later. And I'll just mention that phenobarbital at the VA does exist. They have a protocol that's somewhat similar to the UW protocols, though I think with a lower loading dose, and so you might need more PRNs. It is more restricted to patients with, who are in the ICU or at severe risk of withdrawal. So it can be given on the floor, but mostly in patients with risk factors. And I've heard through the grapevine there's some kind of reservations among nurses about giving additional phenobarb pushes on the floor. So I don't know if that's changing. I think it probably will, but there's a little bit more of a culture of doing the lorazepam-based protocol. All right. So to kind of bring phenobarbital back home, some pearls and precautions, just important things to know, I think, are that the typical therapeutic range of phenobarbital level is 10 to 20 for alcohol withdrawal. Kind of interestingly, the therapeutic range for epilepsy is 20 to 30, so quite a bit higher. Toxicity is usually not seen in serum levels under 40. And the serum level in general is useful not only within that hospitalization to assess toxicity, but for future admissions possibly. So a patient who is therapeutic, let's say at 15, will likely be therapeutic at that same level at a future hospitalization. It's safe to give a loading dose up to 30 mg per kg without checking a level. And it's okay to load phenobarbital even if a patient has received benzos in the ED. It's probably advisable to wait at least an hour before loading them with phenobarbital. But if they're symptomatic, you can feel pretty comfortable that it's safe to give phenobarbital, especially in a monitored inpatient setting. And then some cautions about phenobarbital: you really shouldn't give benzos after you've started a patient on the phenobarb protocol. You can redose with phenobarb as needed. You should counsel patients against alcohol use if you think they're going to leave the hospital after you load them. Ideally, they should stay inpatient throughout their course, but if they're going to leave AMA or something like that, really counseling them that alcohol could interact with the phenobarb and enhance toxicity is important to do, and lots of drug interactions. All right, I see a lot of questions popping in here. Okay, yeah, Megan, I think that's a well taken point in that once you're at that level of 20 to 40, the risk of seizures or severe withdrawal is very, very low, and managing symptoms with adjunctive therapy. I've heard that too, and I think that's a very good learning point, that you can feel that this patient is probably quite safe once their level is at that is in that range. Okay. I'm actually, for the sake of time, gonna just really quickly go through management in the ICU. Essentially, I wanted to point out that for non-intubated patients, it's very similar to care on the floor. For intubated patients, you have more options, including midazolam infusions or propofol infusions. And then you also have more options for adjunctive strategies or alternative strategies with ketamine and dexmedetomidine infusions. And then monitoring in the ICU is a little bit different. CY only works if a patient is alert and can participate in the assessment. And so RAS scores are often used in the ICU. Can I just do a time check, Lindsay? How much time do we have left, or should I try to wrap it up here?
I think Ken's going to join for the house staff meeting, but I'm thinking maybe if we can do two or three more minutes and then take a 5-minute break.
I love it.
Sound all right? Okay.
That sounds great. The rest is, I think, additional. So this is just showing some adjunctive treatments with evidence. I'm not gonna, I just, because we're limited on time, I won't go through it, but it's here if anyone wants to come back to it. These are all adjuncts kind of designed to be given in addition to a GABA-based protocol, with the exception of valproic acid, which is being studied as a monotherapy. And then just shout out for thiamine. This is just so you have the dosing in front of you. The empiric Wernicke's treatment dosing is the 500 Q8. And then Wernicke's prevention is IV daily doses. There's very little downside to IV thiamine, so no one would fault you for the high dose kind of empiric treatment. And then I just included some info on banana bags because I'm like, what is that in the ED? Why are they yellow? It's etc. It's just like a combination of fluids and multivitamins, which is why it's yellow, and thiamine, but there's not enough thiamine in it to treat for Wernicke's, so you'd have to give additional thiamine on top. Okay, so to summarize, this can be my last slide. For inpatient treatment, both lorazepam and phenobarb protocols are acceptable in the treatment of alcohol withdrawal. There is some evidence that phenobarb is superior, but there's still, I think, more research to be done with high quality head-to-head trials to make a definitive determination. Deciding on a treatment approach, you should consider specific contraindications to either benzos or phenobarbital. Always think about drug interactions and possibly consider withdrawal severity in your calculation. There are lots of adjunctive treatments available. Some are available on the floor, some are specific to ICU, know that they exist, and treat every patient with IV thiamine. Actually, alcohol inhibits gut absorption of PO thiamine, so it's not as good. Bonus content. Yep. All right, thank you guys. I'm sorry it was kind of a crunch. I don't know if we have time for questions or just head to break before Ken's meeting.
Maybe Jason, if you're okay sticking around during the break, if
For
folks,
sure.
have questions they want to ask. But otherwise, if folks want to come back at about 10:50. And yeah, lots of thank yous in the chat for you, Jason. I think there were a couple questions going back, but feel free to, I don't know if you've kind of.
Yeah, I'm looking back now. Let's see. Yeah, I think there's good discussion about DOACs and anticoagulation, which, you know, I really didn't dig into for this talk, but I think is actually really important. It seems dangerous, Celia, that people are getting their anticoagulation like stopped or deprescribed. So that's maybe something to think about for the future. And I'm looking at Luke's question here. Yeah, the phenobarb half-life is extremely long, which is why it's also a reason why it's a good option. I don't know if giving maintenance dosing does a lot. I think that just kind of maybe contributes to like their overall level and maybe is more of like a marker of inadequate loading up front as opposed to having breakthrough symptoms. But I think you can feel pretty good about like giving maintenance doses or even like an additional PO dose when you're checking levels and managing symptoms. And then the pause. Yeah, clinical judgment and the pause. Yeah, I share your like interest in like how good the data was for this pause study, and I'm not sure why it's not in practice as much. I think it's something to maybe try out on your own. I think it's probably just like cultural and not and maybe just the thinking about like the added time of like looking up this tool. Oh, interesting. Yeah. Okay, yeah, I think I see a lot of the rest of these are about like getting pushback from pharmacy or either ED or nursing. And I think what Tessa Steele is kind of like preaching and saying to folks is like, we're probably not loading people enough. We should be feeling more confident about these bigger loads and knowing where the level is. And so I think we should be advocating for like for this kind of therapy because I think there's pretty good evidence for it. and just kind of talking through with nursing and with ED providers if there's resistance, or pharmacy, that this is part of the protocol. It's new, but there's a pretty good basis for it. All right, I think that's all I see.
Yeah, I think that was amazing. Thank you so much, Jason, for answering those questions. I think I see Ken here, and we're gonna still take a couple more minute break.